Well, welcome to Let's Manage Endo. This is a program, a series of podcasts about the information and tools that you need to manage the symptoms of endometriosis and pelvic pain. And my name is Professor Louise. I'm from the University of Adelaide, and I work in fertility at Embrace Fertility as well. And my topic today is to explain about endometriosis and fertility. We do have a disclaimer, so this isn't medical advice, it's really information that you can use, but if you have a medical problem, you do need to consult a medical professional. But it's something that you could discuss with them, and hopefully it will give you some information. I lead an endometriosis research group at the University of Adelaide, but I have a clinical practice as well, and I have an IVF unit called Embrace Fertility that I work in, and my main group of people I see are people with endometriosis. They ask for my top tips and strategies, and they are to check your ovarian reserve, to get an endometriosis ultrasound scan, and to know your fertility options. And hopefully this talk will explain why I think those are three things that are very useful for you to do if you want to know about your fertility in terms of endometriosis. I want to first start about how endometriosis affects fertility. And what we know with endometriosis is that the lesions are up in the pelvic cavity, and they respond to your cyclic menstrual hormones. So in the first half of the cycle, like the lining of the womb, endometriosis will grow and be stable. But then when you get to the point of your period, the cells break down and you get an inflammation in the pelvis, and that's what causes bloating and pain and pelvic pain at the time of your period. Once you go past that phase, the tissue starts growing again and it starts healing and repair, and then will come back to be a stable lesion. It's just at the point where the tissue breaks down, you get an inflammatory response, and the immune cells will release chemokines and cytokines and inflammatory markers that will affect eggs and sperm and embryos. And that environment is a little bit tricky for the eggs and sperm and embryos to negotiate, and some of them won't make it. And some of the cycles, you may not get that chance of pregnancy that you usually would have. And some of the eggs and sperm and embryos may not survive it. So it can delay pregnancy because some months the eggs and sperm and embryos have been overwhelmed by that environment. But at other times they survive and they fight their way through it, and you get pregnant naturally. So certainly with endometriosis, we would never expect it to. We don't talk about infertility because many people, even with quite severe endo, will get pregnant naturally. It's just there's a delay to conception. And some of the times we need other techniques to help those eggs and sperm and embryos survive in a different environment. And there's ways of changing the environment. We know that endo affects different aspects of fertility. It can affect the lining a little bit, particularly if the adenomyosis is around. It can affect the quality of the eggs, but often there are really good quality eggs, some in the middle and some that might not be quite so good. It can affect sperm. So if there's a mild male factor issue, the environment will make it a little bit harder. And it can also just affect the way the eggs function. And a little bit, there's a few hormonal changes from the inflammation as well. What we do know is that people with endometriosis have lower numbers of eggs, and it can impact the quality of some of the eggs, usually not all of them. And we know that when you measure markers like AMH, and AMH is a hormone secreted by the cells around eggs. So the higher the AMH is, the more eggs you have each month that the one is chosen from. When we actually biopsy ovaries from people with endo, we can see the egg numbers can be lower. There is a lower response to IVF drugs in people with endo, but we still often get good quality eggs. So the IVF pregnancy rates are reasonably well maintained, because we do find the 1 or 2 that you need to have an ongoing pregnancy, and you only need 1 great embryo to have an ongoing pregnancy. But we also know people with endo go through menopause a little bit earlier. And it doesn't mean everyone with endo. So there's a lot of variability, and that's why measuring the numbers can be really helpful, because if you have a smaller group or a lower number, you can do things faster in terms of fertility treatment. If you have a higher number, you may not have to rush. So knowing that number is really important. What we'd also know is the environment can affect the quality a little bit, and we can see that when we look at eggs and sperm in the lab, or when, when we stain to look at the chromosomes as well, and they can be a little bit affected. And you can see in this picture here, one of the chromosomes has gone the wrong way, and that can be a little bit more affected when we put peritoneal fluid from women with endo on embryos in the lab, or eggs in the lab. We can see that there can be changes. But every egg is impacted differently, and some are fine. The way we check your ovarian reserve is that we can do this blood test. It's called anti-Mullerian hormone, and it's produced by these cells just around the egg. And if you have more eggs, you have more of those cells and the number's higher. If you have less eggs, the number's lower. And we can get a good idea of the numbers of eggs we're likely to collect at an IVF pickup. But also you can kind of work out whether we need to do things faster or whether we have enough time. Another way is to look at the egg numbers in the ovary by counting them on a scan. And our scan quality is getting so good now that if we do a scan of the ovaries, they can look at all the little follicles here, and they literally go 1, 2, 3, 4, 5, and they can count them. And this is a really interesting AI tool where they can automate that counting as well. And we can see in this particular person, they have a lot of antral follicles, and we would expect if we use very, very high doses, these are the number of eggs there that are there in that month. And that gives us a really good idea, if we used a maximal dose, how many eggs we'd get with IVF. And this particular person, we'd get lots. We'd get probably more than 30, because it'd be 2 ovaries. But someone else may only have 3 or 4 on each ovary. And then even if we use maximal doses, we're going to likely get 8. And that tells you a little bit about the value of IVF. Because obviously if we get more eggs, you've got more chances, whereas if we got less, you might have to do 2 cycles. And it's useful to know that before you kind of commence your journey. We also can count on MRIs, but it's much more expensive to do that. But MRIs can also give us a good idea of the egg numbers if you're having those done for endo. We did a lot of surveys in the community, and this was actually with another community group called Endoactive, and we surveyed a lot of people who'd had experience of fertility. And one of the very frustrating things they found was doctors will often say, look, you've got endo, get pregnant. And that, we literally had stories of people who were 14 being told that, or people who weren't in a relationship or were not in any possible situation where they could just get pregnant, or and people said they very, very much felt pressured to find a partner really quickly and commence parenthood much earlier than they wanted to, and it really wasn't appropriate advice anymore. And there are also many alternatives. So sometimes people might want to change the timing of when they start conception, but others may think that egg freezing might be a better way forward. Or you could consider freezing embryos, trying naturally, and having embryos to go back to if you're worried your ovarian reserve is too low. Or you can also think of IVF if it's taking a long time and you're trying to conceive one egg at a time each month, so you'd get 12 chances over a year. If we did IVF and we got 12 eggs, you would get those 12 chances in 1 month. And the other advantage of IVF is you've taken the eggs out of that inflammatory environment. So it's a treatment to improve the environment the eggs are in as well. The second top tip is to get an endometriosis ultrasound scan. And I want to just explain what these scans actually do and why they're different from standard scans. So on the left here, this is a scan that shows what most gynae scans will do. And the probe is placed above the uterus. It will look through the uterus and it will look at the ovaries. And mostly a standard scan would not count the eggs. They would just say the ovaries were normal. And we don't really have any idea of how many eggs there. So what it does tell us is that there's no cancer, that the uterus is normal. It gives you a pretty good idea that there's no polyp, that the ovaries don't have a cyst on them, but it really doesn't assess endo. And you would be told that it's a normal scan and no one's really looked for the signs of endometriosis. So this is where an endometriosis scan differs. And in an endometriosis scan, the probe is placed behind the uterus because endometriosis is often found in the dependent parts of the pelvis and behind the uterus. And you elicit a series of very reasonably complex signs to make sure you can't see any endometriosis actually on the scan. And I'm going to show you some examples of endo when you image, and you can see how different it is to a standard scan. So this is a ligament that holds the uterus up behind the uterus, and it's a very common site to get a little nodule of endo. And once you know you have a nodule of endo, there's 98% certainty that they would find endometriosis at surgery, but we don't always pick up superficial endo, so we can never rule it out. There's a 35% chance that it would still be there, okay? So if they pick up a sign of endo, it's very diagnostic for endo. If they miss it, you can't be sure, okay? So this particular triangle shape here is a uterosacral ligament, and it's a ligament that holds the uterus up, and it commonly gets a nodule, and this is a nodule. So if you have a very good scanner, you can see this dark area here, which is a little area of endometriosis. This is a little lesion in that uterosacral ligament. Now, not that many sonographers are trained to image the uterosacrals. It's a specialized gynae pelvic scan solely to detect endo. And many people haven't had the training in this. And we've surveyed about 400 sonographers, and many, about half had not had training, but they understood it and had seen these scans and wanted to learn. The other half had had training, but they felt uncertain about actually recognizing that as a lesion. So you do have to get an experienced scanner, and we are increasingly getting experienced scanners, and we're trying to develop AI tools through a project called Imagendo to teach scanning using AI and automate feedback. And we're also trying to develop a credentialing system so we can automatically see that someone is eliciting the right signs. So we're hoping to give people a lot more information and the ability to get a better scan and help people who want to get better at scanning get there faster. What has been quite an exciting development is the machines are getting better and better. So they're starting to be able to detect very small changes, and the AI can pick that up very well too. And this is actually superficial endo. And you can see there's a little lesion here that in the past we wouldn't have been able to call that. But the pixelation of the hardware in the scans is getting better, and particularly when you have fluid around and when you move the scan, you can see little things flickering in the fluid, and that when you come to surgery looks like this. So you can now start to detect milder conditions that still cause a lot of pain, but at least people know what they've got. And also it helps the surgeons decide what to do. The other thing it really helps is it helps us do better fertility treatment. So we think about 40 to 60% of couples end up with a diagnosis of unexplained infertility when in fact they have endo that is undiagnosed. So a lot of people get told there's no answer, and they go through IVF blindly, and they don't get targeted treatments because they haven't got a diagnosis. And what we know from a really good study that's actually come out of University of Queensland and Geeta Mishra's group, and that's been done by Dr. Moss and her group, and it looked at a big cohort of people with endo many years ago now. And it looked what happened when they got to fertility treatment. And if you were diagnosed with endo before you had IVF, you were less likely to have used IUI. You were less likely to have had very high numbers of IVF cycles, so you got to targeted treatment quicker. And you are much more likely to report a live birth when you compared to a group of people who were diagnosed during their treatment. So instead of getting generic treatment for the first part of your treatment journey, you got to the endo treatments quicker. And that's valuable. It's a lot of time and money and worry in fertility. And so the more we can do to help people get to the treatment they need the fastest, the better. The third thing is it's really good to know what options you've got if you have endometriosis and a fertility problem. And also how you can frame management and treatment. So essentially, when we are thinking of endometriosis, what the goal is to try and reduce the inflammatory factors in the environment around the eggs, sperm, and embryos, so that they don't have to fight to function well, and that we can hopefully get better quality embryos and also better implantation. So there are a lot of things you can do, and there's some reasonably good evidence now that antioxidants, like particularly CoQ10, we have probably the most evidence about, will help by reducing oxidative stress on cells like eggs and sperm and embryos from the environment they're in. And we can kind of counter some of those inflammatory factors with simple medications. And CoQ10 is the best evidence, but some of the other antioxidants may well help too. We've been doing a PhD at the moment looking at lipidol, which is a substance we use to flush fallopian tubes. And there was a very large study out of the Netherlands that showed in unexplained infertility, we improved pregnancy rates by about 6%, and that effect lasted for about 6 months. And knowing that 40 to 60% of those people had endo, because it would have been undiagnosed endo. And there has also been a study for people that then went on to IVF, and it was the endometriosis group that had a benefit from it. One of the research proposals we have in this PhD is that the people who are benefiting because of reduction in inflammation from Lipidol use. So we think it probably is the effects we see with Lipidol may well particularly benefit people with endo. So I think at the moment that's another good option, and hopefully in the next few years we'll be able to work out the pathological reasons why that helps in endo. The second thing you can think of is surgery. So if you remove lesions and endo lesions and the focus of that inflammation, you particularly may well help pain. And endo can make pain a bit worse because it makes the lesions grow a little bit thicker unless you use specific cycles. And if you change the environment, particularly if you're removing adhesions around the ovaries where the egg might not be able to get out, and the fallopian tubes are fine and they can do a flush while you're asleep, which is much less painful than while you're awake. And they can use Lipiodol as well. It may well improve that environment enough that the eggs and sperm and embryos in that particular month on that day are in an environment that is not so difficult to work with, and they fertilize the egg, you get a lovely embryo, and you get implantation. So we know over the next 6 months, surgery does look to improve outcomes with fertility. Comparing to IVF, it's a little bit more controversial, and whether it improves IVF outcomes, we really are struggling to get the data on that, because until we had non-invasive diagnostics, we could only diagnose at surgery and then they had the treatment. So it may, and certainly some individual patients of mine have improvements in egg quality after surgery. But it's a little bit controversial whether you do surgery before IVF or after, because if you do a lot of surgery, particularly if there's an endometriosis cyst on the ovary, we can reduce the egg numbers a little bit. The third treatment option is thinking about taking the eggs and sperm and embryos out of the pelvic cap environment. And the other thing about doing that with IVF is that we can look at them, and we can actually look at the quality, check fertilization, look at the embryo quality, and that gives us a lot of diagnostic information. And ideally, we'd like to use media that's antioxidant and that's going to nourish an egg and a sperm that may be under a little bit of stress in the pelvic environment to create great embryos. And again, with IVF, we tend to get some really good ones, and they will give you every chance of pregnancy. Some in the middle that have maybe had to fight a little bit harder, and some that have been kind of damaged by endo. So we get a few less, but we still often get good quality ones, and that maintains the pregnancy rates with IVF. So I think that it is also important to think about how you organize your care, and the best paradigms are really multidisciplinary, and I'm sure most people with endo would already understand that. We think general practitioners are pretty critical. Nurse specialists are also critical. Physiotherapy, a lot of online information and community supports like Quendo are also really part of the treatment program. A gynecologist and someone who can do good excisional surgery may be that person. Pain specialists, but we would argue fertility specialists are important too. And I certainly spend a lot of time phoning surgeons who are about to do surgery or wanting us to preserve eggs before they do surgery, to just plan that together so that we optimize our care and we help people. And we do have very complex treatment programs that include surgery, that include physio, that we look at different medications because of other treatments people are having, to make sure we optimize our care. And this is the group of doctors I work with at Embrace Fertility, who the other 4 female doctors there do surgery, so I tend to refer to them. I don't do surgery, I mainly do fertility. Jeff and I tend to do mainly fertility, but I also sometimes ask him to help me manage sperm care, which is his specialty, to help a couple who have endo by improving sperm quality. So then we get better embryos, because if the sperm are optimized, they can cope with the environment in the pelvis a little bit better as well. So even with amongst fertility specialists, we work quite closely together in this situation. This is a paper that we wrote about the different things you can do in fertility, and I've really summarized that paper in this presentation. And this just shows how we can make sure we get a good diagnosis, we optimize natural conception, we can use IUI, particularly in situations where intercourses can be very, very painful with endometriosis, and some couples really struggle, but they do want to have a family together, and IUI can be quite helpful in that situation, where we place the sperm closer to the egg and people don't have to go through very painful issues with intercourse. A lipidol flush we sometimes use, and we think of surgery. And then we do quite specific targeted things with IVF. So we have some very good cycles, particularly with egg freezing or embryo freezing, where we're not going to put an embryo back. We're now using a lot of progesterone, particularly for people with endo, because it keeps the lining very, very thin. It stops you releasing the eggs early, and it's a great drug, and it's an oral drug. But you don't get a horrible, horrible period from a very thick lining after the IVF cycle. The problem with that cycle is we can't put an embryo back because the lining won't be receptive. But if we're freezing, it's a very good cycle and that helps people manage pain after they've retrieved the eggs and embryos. So there's some very targeted things we can do if we know we have endo, and that's why getting a diagnosis is important. And we use these paradigms, and knowing the egg numbers are low or high, we can also tailor what we do. And sometimes with low egg numbers, we're increasingly using something called PRP to try and improve the numbers. We can look at specialist media that are more antioxidant, and look at supplements and different ways of reducing oxidative stress as well. These are the research groups I work with, and we are doing we've got a lot of funding to look at developing non-invasive imaging diagnostics using AI. And we're very much hoping that that will just improve people's access in the community to a diagnosis earlier and to better timely treatment. And one of those treatments is, if the egg numbers are low, do we look at preserving fertility? And I think all of those things, hopefully we can answer with a reliable non-invasive diagnostic. We have also set up Endozone and Quendo, and all the other community groups in Australia have co-created this. It's an initiative out of the National Action Plan, and it's a government-funded website so people with endo can also find information from all the community groups, and we have lots of links to various pages, but also for doctors to find information about how to treat well, to keep up-to-date information, and to also interact with the research community so that we can get trials going so we get better and better outcomes. There are some aspects of Quendo which I'm going to let them talk to. They have been incredible support for us, and we are very happy to help them with this podcast and any other things we can do to help their goals, which is to really improve care and information and awareness for people with endometriosis. And we find them incredibly supportive of us, and we think they're an amazing organisation as well. So thank you very much for allowing me to speak today. I hope that's been informative, and hopefully that's given you information you can take to your medical professionals and ask them and help them. Thank you.